Great, thank you for the introduction. Thank you all for being here. I'm excited to talk about this. So, let me just get right into it. So, how do social relationships influence college women's decisions regarding testing for sexually transmitted infections? 15 to 24 is considered the critical period for STDs. They are disproportionately at risk, accounting for half of all new infections, even though they account for only a quarter of the sexually active population in the United States. A large number of people in this age range still do not seek testing. Something like 1 in 4 or 1 in 5 college students will have an STD at some point in their college career, but will not know it. That's a really big problem in terms of epidemiology and disease spreading. Extended sexual networks, sexual concurrency, alcohol and drug use, and the prevalence of risky sexual behaviors among peer groups contribute to high levels of STI prevalence at colleges. So what I mean by that is, for example, colleges are relatively insular environments. You're more likely to date people who are at your school. They're more likely to have dated people who are at your school. You get a lot of overlap in sexual networks, and you get long chains of connectedness that result in higher risk. But many students fail to seek testing due to fear of damage to their reputations or due to a lack of perceived vulnerability to infection. They don't realize that they are at risk, or they worry that someone will think that they did something wrong. Their reputation will be tainted. So I came at this from a social relationships and a reasoned action perspective. So social relationships have been shown to moderate risk behaviors and promote behaviors such as condom usage, better partner communication, contraceptive usage, but little research has addressed how social relationships impact behaviors specifically related to STI testing. I use the theory of reasoned action to examine how social relationships might contribute to this. So this basically says that health decisions are made based on knowledge, beliefs, and subjective norms. So in designing this research protocol, those are the 3 things that I tried to look at. Other studies applying this model have found perception of risk, positive attitudes towards testing, and community perception of risk contributed to an individual's likelihood of seeking testing. So if you are in a community that sees itself as having high levels of vulnerability, you are more likely to get tested yourself because you are more likely to hear about it and more likely to take that risk seriously. So I wanted to know how social relationships might contribute to these factors. I conducted in-depth semi-structured interviews with actually 17 women, but the recording of one of them was damaged, so we'll only be analyzing 16 women attending a private 4-year university in the mid-Atlantic region of the US. Participants were recruited through a number of different avenues. A lot of them were recruited through snowball sampling, so they were referred to the study by their friends. Eligible participants had to be woman identified for this study and had to have been sexually active in college. This was to reduce any patterns about not seeking testing that would emerge from people not having been sexually active and not perceiving themselves to therefore be at risk. These were transcribed and coded. I looked at different pathways, but the most important thing I did with the coding was that I broke down the testing into 3 types of behaviors, and that's what I want to talk about today. Routine, meaning they were either tested at regular intervals or they tested proactively, so, every couple months after they had a new partner or whatever. Sporadic reactive testing, so either testing because they thought they had symptoms or thought something was wrong, or a doctor insisted that they get tested, and no testing. Very few people in this study fell into the no testing category, so I won't be talking about that very much. The people who did fall into the no testing category primarily did so due to a very low perceived risk. They'd often had only one sexual partner in college. They didn't believe that they were at any risk. They had not sought testing. But I do want to talk about a couple of themes that did emerge in this. So the first is that there's still this awareness of the stigma around STI testing. Interviews said that STIs were seen as disgusting or that they were something you should be ashamed of. One of them, and I remember this very clearly, said to me, they're still stigmatized because you never talk about mouth sores, cold sores, the way you talk about genital herpes. They are talked about very differently despite being the exact same virus. And so Several respondents discussed that their peers seemed to think that if you needed to be tested, you had done something wrong. There was this sort of moral failing, this culpability that came with needing to be tested for STDs, whether you actually tested positive for anything or not. They also revealed a belief that STIs were seen as permanent. It's not like you have it one day, it's like you have it and it's with you for the rest of your life. Now, for those of you who work in STD prevention, you know that for many STDs, this is not true. For things like chlamydia, gonorrhea, syphilis, these are bacterial infections which we can cure. But that differentiation did not come out in these conversations. So I think it's worth noting that these people were aware that there is a stigma attached to it, and that this does, for some of them, influence their perception of how they navigate STI testing. They also said that they felt that even though they thought they could be at risk, many reported that their peers underestimated their vulnerability to STIs. And that was something I heard a lot in the proactive testing group. The people in the reactive testing group also believed that they probably weren't at high risk. They had only been tested because a doctor insisted upon it, or their partner had an STD scare, and that heightened their perceived risk. But they thought that they heard things from their peers. There was this awareness of a low perceived vulnerability. They were almost always based on their own behavior or their partner's past behaviors, with no real concept of how they fit into a broader sexual network. It was a very narrow focus. And those participants who sought testing proactively or at regular intervals reported that they felt they could potentially be at risk for infection. So this aligns with those previous findings about how perceived vulnerability shapes testing behaviors. The two really interesting things that I want to talk about, though, are the roles of family members and friends. And I'm in the process of refining these two themes as I prepare this for publication, but STI testing was normalized for several participants by parents, siblings, and cousins, and specifically within this, it was mostly normalized by women, members of their families, so by mothers, sisters, mostly female cousins. Which I think is an interesting gender dimension to this, because it's women talking to women about this particular dimension of sexual health. They mostly recall family members passing this on focused on safety and responsibility. Those are two themes I heard a lot, that it was, it would be frowned upon not to take care of yourself in that way. The emphasis is that sex is good, sex is fun, just be safe about that, which includes not just contraception, but STI screening and being careful. The individuals who reported being unable to talk to their family members, either their family members just didn't talk about it, their parents would freak out if it came up, they were much less likely to report testing proactively, or they were worried about how their parents would react to the idea of them being tested for STIs. Family can be a source, therefore, of both social support and social consequences. The fear that parents will react badly and that there could be social repercussions within the family, financial repercussions because these are young adults who are not yet financially independent. Those kinds of things did come up in these interviews. But I think it's very telling that people whose parents talk to them very openly, not just about sex, but about sexual health and STIs, were much more likely to seek it at very regular intervals. And the other thing that I thought came through really well in the study was the normalization of testing by college friends. And again, these are mostly women talking to women who they're friends with about STIs. There's very little cross-gender pollination of these ideas. Which is something I'm working on unpacking a little further. And so if anyone has ideas about that, I would love to hear them when we get to the questions. So although a large number of participants report talking about sex with their college friends, a smaller subset reported discussing sexual health within friend groups. And this is a really key distinction that I want to make here, because people talk about sex socially all the time. They talk about their relationships, they talk about who went out with who, they talk about who they hooked up with last weekend, but they don't talk about the health aspect of it. They don't talk about the risk, they don't talk about needing to be tested. That element is missing from a lot of conversations. For the people for whom it wasn't missing, they were more likely to say, oh, it comes up when I get tested at my annual. Oh, it comes up, it just comes up. We talk about getting tested. We talk about where to get tested. For several participants, they and their friends saw it as being expected, a part of being responsible. That responsibility theme comes out in the friendship conversations too. The conversation is always sort of just do it. I feel like in my life, I feel like I should be a responsible person. I'm sure that comes from having equally responsible friends and family who've just kind of given me that value. STI testing, the idea of being responsible for yourself and the people you come in contact with. Friend groups played a very important role for these young women in influencing or reinforcing attitudes and norms about the STI testing being about being safe, healthy, and responsible. I think this is a very important contrast to the more generalized messages that they are getting from their peers about culpability, failing, etc., that we see when they talk about stigma and vulnerability, that the idea that if you need testing, you must have done something wrong. This is an important counter-narrative that played a very big role in deciding whether or not these women proactively sought testing, or whether or not they saw it was something they just did if there was something that was wrong. Couple of limitations that I do want to mention. This is a pretty limited sample size, and it does have limited diversity. It's not representative. I'm not even going to go so far as to say it's fully representative of the school that it was drawn from. So it's also impossible to fully generalize across college context due to differing school community norms around sex and sexual health. The site of the study was a left-leaning, 4-year private university in the Mid-Atlantic region. Students would describe it as being pretty liberal when I asked about it. Almost all the students would describe themselves as being middle class, which sociologists will tell you almost everyone says they're middle class, whether they are or aren't. We're just all middle class somehow. And so that doesn't give me a lot to unpack from the demographic perspective. So I do want to at least acknowledge that those are some limitations to this study, but I do think that the themes that emerge are worth further pursuing. Some just key conclusions to wrap up. These support claims that an ecological model to promoting STI testing would facilitate sustained behavioral change. That instead of just giving people messages through education and hoping that they'll stick, their social environment plays a very important role in establishing norms, knowledge, and beliefs that shape their decisions about sexual health. Parents, peer-aged family members like cousins and siblings, and college friends, but not really high school friends, play important roles in normalizing STI testing for young women and may help to shape their knowledge of risk and attitudes towards testing. The role of parents and other family members is in regards to sexual health decisions, is very underexplored in the literature and is deserving of further empirical exploration. I am looking for ways to do that now, so again, any suggestions are welcome. And that's it for my presentation. Thank you guys.